Okay, great. Thank you. So the past year has been quite an interesting year, both challenging, interesting, but we also had to learn a lot quite quickly and adapt and sort of make our services adaptable as well, while considering our patients and the workload that we had to deal with. So it's a very short reflection because we've been given around 10 to 15 minutes each. But I hope that I'm just going to capture the feeling of every doctor in the country. I'm going to be a little bit into rehab as well, because I mean, I'm very interested in what the rehab team does, and I'm very much aware of some of the challenges that went through for this year.
So just try and
Okay. No.
Sorry. Slides are not on the computer. What is your name of your computer for host again? Jikanati. Sorry.
Yeah, it's just the design. Yeah. I thought it's very rural, very ghetto. Yeah, it's only a few. Only a few. Okay, great. Okay, great. All right, I think we're ready to move on. So just on the definition, I'm sure we all know the definition of equity, but what really captured my eye was an article, the reference is at the bottom there. It talks about equity being a human right. And if we do not really attack this with that mentality that it is a human right, and if we are not providing proper care, especially to rural communities, then we are infringing on their rights. Then we really need to rethink how we're going about advocating for equity in our rural hospitals. So that article really just captured my eye.
Sorry, so what's happened is our slides are advancing, but not the slides on there for the group that's watching. So
Okay. Okay, I suppose while we're waiting for them, I can actually read what that article said, but I'm sure you can also read for yourself. But it basically says equity in health is the absence of systematic disparities in health or in the major social determinants of health between groups with different levels of underlying social advantages or disadvantage. There is wealth, power, or prestige. I've actually got Dr. Friedland, who's sitting right at the back. He once told me that when you want to spell health, you must never leave out the W for wealth. So he will type health as a hybrid wealth in a way. So you always have to consider the social determinants of health when you're bringing in health into a community. And when you talk about equity, then we have to be thinking about these social determinants of health.
So you'll find out, so when you start changing.
Okay, great. All right, great. So just a few things that we realized, especially in rural. We know that already 42% of the South African population lives in rural, and we know that only 15% of the doctors provide services in rural areas. We know that it's only 20% of nurses in South Africa provide care in rural. So obviously, we are already coming from a place where human resources are just not enough. And then COVID came as a pandemic. And this is where then we realized that actually we are far worse than we thought. So human resources for rural hospitals meant that some doctors needed to be at work looking after COVID patients, and some services. And I'm actually happy that the MEC of Limpopo mentioned some of these things, that some services had to be stopped because human resources had to be diverted from surgery or from other departments, just so that COVID cases can be looked after. We know that equipment is not available in sufficient numbers or quantities in rural hospitals. So you find that there's only one ventilator. I'm happy there is someone from Manguzi here. So from Seleni, we actually happen to have about 3 ventilators. And for us, that was such a luxury that we had to lend one to Manguzi. And I mean, you can see at that point, Manguzi didn't have a ventilator. So we had to share. And at that point, Manguzi was actually then the designated isolation hospital. How do you make a hospital a designated COVID hospital without a ventilator? So moving on to supplies, we ran out of oxygen. Like, who would ever think that we would run out of oxygen? But it's not just oxygen within district hospitals, oxygen in clinics. You'll find that patients will be waiting for ambulances in clinics, and their one oxygen cylinder that they survive on would literally run out. And that will mean that that patient basically is dying because they don't have a basic resource that they need at that particular time. Ambulances, PPE, we had to depend on sometimes the district saying, hey, come and collect some PPEs for yourselves. Or you are not happy with the supplier or the quality of the PPE that they're bringing in. So you have to turn it back. I remember the one time there was a sanitizer that basically chipped our healthcare workers' hands. So we had to return a whole batch back to them. So these are just some of the things that we had to deal with. The referral systems, the MEC of Limpopo was just talking about that. In KZN, there was no ventilated bed for a COVID patient that needed ventilation. Basically, almost all the COVID units will be full whenever you needed to refer a patient. But then how do you also refer a patient on CPAP in an ambulance? So all of these things are things that became evident. And I think at the back of our minds, we're always aware that we have scarce resources, but it all just became a reality when all of these things happened. Technology. I think for me personally, I've been one person who's always been quite ignorant or naive about this. I strongly believe that a lot of people owned smartphones until we needed people registering for vaccination. And then I remember in the RuDASA executive that we were discussing the one day, and my question was, do we have any evidence for how many people actually own smartphones in rural communities? And it's surprising that it's as much as professionals and people that work, we have so many smartphones and we're so exposed to technology. Okay, I think the slide has changed. Yeah. Yeah. So a lot of people have smartphones, and we are exposed to them, but we don't look at the poor population that they actually don't own smartphones. And now that they have to register for EVDS and to get vaccinated, then everyone is like, oh, okay, this is news to us. And then there's the issue of reception that we as rural hospitals have always actually complained about. Sometimes you're unable to get hold of a doctor on call just because there's no reception in hospital. And this became even more evident and urgent during this time. And then social determinants of health. I think something is going on, but I think I will just carry on talking. Yeah. Okay, so social determinants of health. How do you ask someone with no water to keep their hands clean? How do you ask someone with no toilet to keep their environment clean? How do you ask someone to come to a hospital or a clinic when they are not well, when they actually don't even have a road to come to clinic, when they have to cross a flooded bridge, when they have to come to clinic? So these are all the resources that really became evident that we as rural health doctors need to advocate for better equity for our rural population. And then the next topic for me was access. The MSc also mentioned a little bit of this access to services, even routine care. I'm sure some of you have noticed that even the EPI, the extended program in immunization for young children, the percentages or the statistics dropped because everyone is scared of COVID or there's social distancing at the clinic. One of our clinics, so primary healthcare services that we offer under Mseleni. One day I was visiting the clinic and I was actually surprised that all the vehicles are parked outside and the queue literally runs outside the gate because there's just no facilities within the facility for everyone to wait with social distancing. So a whole lot of people will see that and they will turn back and say, I'd rather come back another time. So we need to be looking at those things with a much, strict, Anyway, let me move on from that. Transport. I would say that one of our first cases under Mseleni came in from another province, and she was in a taxi. So a whole lot of people within that taxi got infected, and that's how COVID spread within our area. And then after that, people were scared to be within public transport systems. How do you then access care when you don't want to be in a public healthcare or public transportation system? CCGs. I'm sure a whole lot of people love CCGs or community caregivers, but at some point when the COVID pandemic started, they were told to stay at home and not work because of the risk of exposure. And this means that now I would touch with the rehab idea that a lot of patients that are looked after by CCGs were at a disadvantage during that time because they didn't have any home visits, they didn't get seen. Some of them had to be, or some CCGs actually deliver medication to these patients and some supplies like nappies, gloves, and CCGs couldn't access those patients. So they were actually at a disadvantage. Dental optometry, we're told those were very high risk groups, professions, and they had to close down in facilities. I remember someone calling me and telling me, my tooth is gonna kill me. And at this point, what do I have to give them? Because our dental services have actually closed down. Surgical services, the MEC has already touched on this. School health was actually stopped because school health teams were diverted to being community tracer teams. So schools children were not being weighed. There was no education going on in school by our health teams. CCMDD, we've actually got piles and piles of parcels that have not been collected because people just won't go to collect their CCMDD, but then, or CCMDD packages. But then there's also CCMDD packages that are collected from within healthcare facilities. And with social distancing, like I've explained, people would just stand back and not bother going into the facilities. And then vaccination. With healthcare workers, some institutions had to travel. I remember for our district, some institutions had to transport their staff. I think round trips were probably around 350 kilometers just for them to get a jab. and for us, it was just like, okay, how do you even get there? How many staff are you willing to let go in a single day when we're in the middle of a pandemic and already struggling services? And yet you have to take staff across a district to get vaccinated. So we really need to be thinking more about these things. Meetings, yes, they were online. Yes, this provided better access for us rural communities, especially because I would quote KZN, often a meeting is held in Pietermaritzburg. To get to Pietermaritzburg from where I work is probably about 4.5 hours. But if a meeting is on Zoom, then it means better access. Unfortunately, with technology, that there can be problems as well. Next slide. Okay, as much as we can look at challenges, I personally think that there were some wins as well. One of my personal goals has always been outreach. I think that as rural communities, we try to do outreach, but I think we haven't really gotten a proper model. I always look at a Cuban model where we would know each and every single household within our sub-district, and we would know who lives in there. And I think we somehow managed to do this with our tracer teams for COVID, because we knew where our COVID cases came from, and our tracer teams were actually able to then trace their steps back to their household, back to their workplaces. Okay, I'm getting an echo. All right, so back to their workplaces. We even knew when someone traveled after a COVID test all the way to Joburg, and we could trace those people. And I strongly believe that we can duplicate this model to look at other chronic diseases. We have a lot of laws to follow up for HIV and TB, for diabetes and hypertension. Can we not do this model and just duplicate it for those programs as well? Access to information. Thank you, Steph. I mean, RuDASA was one such point where we developed a daily digest where there's just constant information flowing. Yes, whenever there is too much information, it can get quite flooded as well. But I think there was just so much access. And then the support, like I've never seen so many meetings between district and province and national. In our sub-district, we literally had a district meeting every Monday. I don't know in other areas, but I think just that, knowing who's doing what within the district, where you can get help if you run out of oxygen, where other things are supposed to be, and just sharing that expertise and ordering of equipment. I thought this the support was a definite win, and I think we need to be duplicating these things in moving forward. And then the innovation, we get people manufacturing CPAP masks, and amazing work went into COVID response. So amazing wins as well. So yeah, I think just on that note, I would like to thank everyone for your time, and again apologize for the technological glitches, and particularly I would like to thank the RuDASA executive team that has worked tirelessly during this past year. Thank you very much.
Thank you very much, Lungi. Yes, I would love to get RuReSA to come and join us next and give us some feedback on the rehab side of things. Do you have a presentation that they need to load for you? Okay, great. So you don't need a screen.
So, welcome to everybody, and thank you for bearing with our technological demons. We hope that we have brought rural timing to our event. So, my name is Marika Visednit, and I'm from RuReSA, which is Rural Rehab South Africa. I was part of its starting group under the tree 10 years ago, and I'm still here. And we'd love to get some new blood. So, so yeah, extending that invitation out there. Rehab started off on a back foot, already being highly fragmented with huge inequities across provinces and regions. And with a heavy focus on the acute management of COVID, very few parameters were given to guide individual rehab departments in restructuring their services. The inequities in access to rehab and the gross disparities in the rehab departmental responses just further widened. It was never going to be a phenomenal response, I think. So people with moderate and severe disabilities and their families experience multiple barriers in accessing and remaining in healthcare, and are more likely to incur catastrophic levels of health expenditure than the general population, leading to decisions to forego visits, as well as perhaps borrow, sell off, etc. Lockdowns and subsequent civil unrest have exacerbated unemployment, and many rural families found themselves suddenly having to feed more mouths on the same number of welfare grants as people moved back to their rural homes. The individual stop-start approach to outreach across the public health sector for general healthcare as well as rehab services have interrupted chronic care across the country. In areas where services have continued but been centralized, the risk of catastrophic health expenditure by people with disabilities and other vulnerable groups and the levels of unmet need has risen exponentially. With rising austerity measures, and I want to say, how much longer do I really need to repeat this? And the subsequent rehab post-freezes, again, how much longer do I really need to repeat this? Greater emphasis is needed in strengthening local disability networks and engaging end users in service delivery. It's a hard task where there is still no clear progress in developing the peer supporter and mid-level rehab worker category. Access to assistive devices has always been severely inequitable across the provinces and regions. For more information, please look at the South African Health Review of 2020. The chapter by Teresa and Andy Gray outlines just how bad these disparities are. And with outreach services and supply chain interruptions, access to devices, including the maintenance, repairs, and reviews, has been severely curtailed. Children and adults with disabilities have lost precious rehab time, have had challenges in accessing their chronic medication and checkups, and have witnessed elective tertiary services all but shut down. With a large amount of emphasis on telehealth, the upside for rural patients was a greater willingness by clinicians on both sides to engage in case discussions over platforms such as RuDASA. The potential of this service to increase access to care and reduce costs to rural clients is significant. Rural therapists also made use of the old telephone, contacting known clients and just asking them how they were coping, what their needs were, and giving them advice over the telephone. Some tertiary hospitals with clients with smartphones, Lungi noted, developed rehab exercise packages that could be WhatsApped via departmental phone. whilst other rural hospitals use peer supporters and their networks as an early warning or referral system. More emphasis has been placed on the need for refurbishing assisted devices, as more and more hospitals experience ever-shrinking assisted device budgets. Again, do I really need to repeat this further? However, the review and return rate depends heavily on a department's community footprint. Pockets of disability and rehab good practice across the country have emerged, and RuReSA has made an effort in sharing these across its various network platforms in the hope to inspire others. However, the impact that institutional management practices and resources have on local rehabilitations departments' ability to respond must be acknowledged. Higher education has borne a particular brunt, with rehab students' curriculums designed for maximum hands-on training and patient health system exposure reworked into online lectures. The lecturers have done a remarkable job, working around the clock and coming up with ever more innovative ways to bring across theory, practice, and reality, going as far as reaching out to RuReSA members to prepare Zoom talks, videos, case studies, and practical online lectures from the field. The 2020 final year students seem to have coped quite well, testimony to this extraordinary effort, and those that have been placed rural are demonstrating that many of the anticipated gaps can be overcome with time, contextual support, and supervision. Unfortunately, due to the fragmented nature of our services, this is not always a guarantee where they're placed. As always, current community service therapists retain strong networks with others from their year. Networks largely inaccessible to those of us who have long since graduated. It's these networks that RuReSA still needs to make inroads into to strengthen communication efforts around go rural, stay rural, and make it a gap year. As South Africa's economic situation worsens, strong attention should be given towards this campaign, and meaningful rural and primary healthcare training exposure for rehab therapy students needs to be monitored very closely. With severe disruptions come the potential to initiate health systems changes. And this opportunity, when seen alongside South Africa's hotly debated proposed health reforms, must be firmly grabbed. Parliamentary NHI hearings, the Primary Healthcare Standard Treatment Guidelines Review, and the Certificate of Need were three major policy-level opportunities which presented themselves this year. Thanks to long-standing relationships with the rehab professional associations, a collaborative approach was possible. Gwyneth Lowe's research department from the University of Stellenbosch took a leading role in coordinating rehab inputs into the PhD SDGs, a mammoth task in an incredibly short period of time, which one has, to our knowledge, not been attempted to date. That means she has done it, but nobody else has tried it to date. Sorry, just a clarification. As the guideline developments follow a rigorous methodology not particularly suited to rehab, this was a significant challenge. Standard treatment guidelines contribute towards the development of the health benefits package under the NHI. The exercise in trying to bring rehab into these guidelines, as well as the exercise of highlighting the numerous data deficiencies, data that is required in monitoring the inequities in health coverage for people with disabilities, for the parliamentary presentation, have shown us just how much systems-based work is required. So what did RuReSA achieve this last year? We convened and drove the first rural rehab research group. A rural research repository is currently under design with the aim of building a library of research literature relevant to rural rehab, in addition to our current library of resources currently kept on drive and open to RuReSA members. Parliamentary input on the NHI and the current inequities in accessing rehab was given, and data deficits in monitoring inequities for people with disabilities were highlighted. Initiating and supporting the initiative to pull refer to rehab into the PHC standard treatment guidelines, together with other professional associations, and coordinated and spearheaded by Gwyneth Lowe. Online presentations, case studies, and discussions with undergraduate students with regards to providing services in a rural area was offered. We expanded our networks beyond our national boundaries. We gave a presentation on the social effects of COVID and the examples of rehab departmental responses to the crisis, to the WHO Africa group, and joined the COVID Africa group. Individuals from RuReSA also presented on various platforms, including the Africa Spinal Cord Network, the World Confederation of Physiotherapy, and the US Organization of Hand Surgeons on particular rural realities and innovative solutions. Interprofessional Rehab Indaba. This is a group of professional associations as well as public sector groups that get together to discuss shared problems. We continue to collaborate with the associations in this group in discussing and tackling problems shared across rehab professions. And we as RuReSA try to instill the rural reality into discussions and insist on equity lenses. Members of RuReSA authored and reviewed chapters within the 2020 South African Health Review, an issue which was entirely focused on disability. And it's most certainly a review worth reading. The inequities have widened and the work ahead of us is daunting. The number of presentations by rural therapists showcase innovative work and strategies to address local inequities. And we hope to see you in these sessions in the next couple of days. By sharing ideas and strategies, we can spread the love and we can really tackle the inequity ahead of us. Thank you.
Thank you very much, Marika. So I'm going to now, I thought we'll go in the order of organizations as they arose. So I'm going to ask PACASA for our clinical associates. Oh, okay. So let's go on. Okay, because so RuNurSA is going to come and then PACASA is going to join us on Zoom. And is the PACASA representative on Zoom? Can I just check if the person from PACASA on Zoom?
Yes, I'm here.
Right, you can hear us and, okay, good.
Yes, thank you.
Excellent, yes, looks like that's going to work. Maybe let's maybe perhaps just do the presentations of the people here, and then Sanele, we're going to hand over to you. So yes, if we can invite our nurse representative, the youngest rural health baby, to the front to come and tell us about their last year.
Morning, everyone. My name is Tabisa Ngakaza. Tabisa means make people happy, with the hope that at the end of the presentation, you'll all be happy. Ngakaza means to gamble. It means we are going to gamble with the information that I'm going to give you. I must make a disclaimer. I'm not the chair for RuNurSA, and I did not prepare a presentation, but nurses always know what they do as the background, as the backbone of the healthcare system. I'm here to talk about the past year through an equity lens. For the first time in many years, as we know that each year on May, we celebrate International Nurses Day of Prayer. What do we celebrate? The work that the nurses have done for our communities. But for the first time, we had to do that. We celebrated that that year in a most unexpected way by fighting a worldwide pandemic with our own health. Nurses were the ones that were affected mostly by this pandemic as the forefront, as the ones who are dealing, even if we can say social distancing, but there's no social distancing between a nurse and a patient. Because how can you manage the nurse if you are in a social distance? So because of that, they were the ones that were affected. The work that nurses do was foregrounded by the media, and we have been heartened by the new funds and support from the public. Rural areas were affected as usual in bearing the brunt with untold staff shortages and PPE supply issues. When needs are determined, it is necessary to analyze all the objectives of the department or unit. So it was the case with the nurses as well. A comparative historical analysis of the previous year's budget was used as the guideline to check how much do we have? Are we going to cope with this pandemic? Since we know that this COVID was not budgeted for, we had to liaise with finance management of the health services in all areas. We had to put customer needs based on the profile analysis of the current and the previous years. The following questions were used as the guidelines. How are the income and expenditure of the institution is going to be calculated? Should we generate our own income and work out the budget accordingly, or are there other sources of income? The answer was no. You have to use the current budget that you have. That is, as well as the current resources that you are having, you have to make use of those effectively and efficiently. That is quality. Does the above play a role in budget decisions? What is the current patient customer profile of the institution? So we had to design a tool in order to check the bed status of the patients that we are admitting in our units in order for us to repurpose the beds that we are having in the institutions. We did not have extra beds to admit the COVID patients, but we were informed that since COVID is here, we have to nurse those patients. Will there be new or other personnel, for example, the medical practitioners, with new ideas or preferences that might affect patient care and costs? The answer was no. The very same human resource that we are having, we need to equip them. We need to capacitate them in terms of managing the patients with COVID. There comes EVDS to our rescue. Knowledge Hub was of great help for all of us. In terms of training, we had to register through that hub so that we have a better understanding of what this COVID is and how do we go about managing it, so that we have answers when our community asks us, because we are the only source of hope for our communities. They rely on us. When a patient sees a nurse, it sees a healing. It sees an angel. It sees a hope So we had to carry those burden. Okay. What renewal projects were envisaged, such as patient education programs and quality improvement programs that we need to have? In return, with the knowledge that we have, we had to go back to the community and educate them so that when this COVID hits them, they must know how to manage their relatives. They must know how to take care of their families, and they must know how to protect themselves from this COVID pandemic. What were the deficits of the current budget? Where have we over budgeted and where have we under budgeted? Because we didn't have a separate budget to employ more people, we had to use the same COE that we have under our budget, under our normal budget, to employ people to work in this separate unit that we have to open all of a sudden, that never had before. For instance, the hospital I'm working in is a 210-bedded hospital. And it is in the far rural areas of the South Coast in Harding. We had to cater for those patients. In catering for those patients, we had to allocate staff. There was no way that we were going to say, as the nursing manager, I don't have a nurse to nurse those. We had to see what to do. And then finance manager had to reshuffle and do the budget analysis to check in the expenditure, see in the goods and services, because we needed to have PPE. PPE to protect the very same staff. And PPE was made not a matter of choice. Comfortable or not comfortable, sick or not sick, suffocating or not suffocating, we were made to work with our masks on. There was a joke from one of the patients. She was asking, we were educated in the time of HIV, but you've never seen us coming out of our homes wearing condoms. But what is this now? So we had to transform, we had to adapt, we had to accept that this is something that we cannot change. We had to learn to live with that because COVID is here to stay. And then what is planned for the next year in the very same environment? There comes the vaccine. Like any other disease, when there is a research, the researchers will come with a vaccination to cure or to prevent death or severity of that disease. But there was a hesitancy. It started with us as nurses. So as the advocates for patients, we had to be strong. We had to be the pioneers to say, please, Tumami na Baba, I'm going to take the vaccine. So if it is killing, it must kill me first before it can kill my patient. As in our pledge, we say, we are going to make the patient the first consideration, and I will hold in confidence all the information that I have between me and my patient. So we had to still do that. Okay. Then we got vaccinated. After getting the vaccine, then we saw that by the matter of time, there were no side effects. The minor side effects that were reported were not alarming. And then we had to sit down and analyze which groups of healthcare workers did experience the side effects. And then we find out that the ones that were having the comorbidities earlier, but who did not take care of their comorbidities, will experience the minor comorbidities. But the ones with the comorbidities, but who are taking care of their comorbidities, like our HIV patients who are adhering to their ARVs, there were few of them that getting the side effects. So we had to preach that gospel to say, if you know that you are having a comorbidity, that is a health condition, you must take care of that condition so that COVID doesn't get a slot. As we have seen that the COVID will chip in if there is a gap that you have opened between you and your comorbidity. So we had to preach that. Okay, which external influences might possibly have an impact on the budget? For example, we had the strikes, the riots for people who do not want to take care of the COVID patients. But as nurses who are skilled, we managed to conquer all those. For instance, in terms of testing the COVID, taking swabs, the first healthcare worker in the whole institution to be taught how to take a swab was the nurse, because doctors were afraid that maybe they can be infected. I remember the first case that we had in my institution came through a bus, Inter-Cape from Cape Town. The whole bus became chaotic. They were saying things to say, this patient knew about her status all along because we have seen her, how she was behaving in the bus. And yet, poor kid didn't know anything. She happened to be amongst the mass screening that was done, mass screening and testing in Western Cape. And then, because the results didn't come, then she has to go home, which was KZN. So she has to go via the bus, but most unfortunately for her, the results came through her cell phone while she was in the bus. So what she did was an honest thinking. She went and informed somebody that I've just received my results and I'm positive. What do I do now? You can see the chaos that was in that bus. There were communications from left, right, and center. The district office panicked. The district office panicked. And she informed the CEO to actually inform the police around the area to catch the bus, as if that patient had committed a crime. Because it was new to all of us, we didn't know how it affects. We didn't know how it will attack us. So she was made to walk from town to the hospital, escorted by the police van. Why? Because the police didn't want to put her in their van. They asked, who's gonna disinfect this van after we have put her in our van? It was a matter of changing the mindset to say, there's nothing wrong with this. You'll just disinfect like any other infectious disease, and that's all. So the manager for the bus had to change the bus for the passengers to continue with their journey, because some of them were still going past Harding. So time was lost for them. The nurses were made to go and calm those angry passengers as the advocacy for the patients, to say, just calm down. We are trying to organize something to take you home safely, and would like to ensure you that you'll be home safely. Furthermore, it was necessary to prioritize in the view of the health services. Therefore, so much as we had the schedule for all the meetings, we had to withhold some of the meetings and prioritize the important ones. We had to withhold some of the procedures and then take the emergencies only. Not forgetting that those decisions were affecting our patients. So we had to be the go-between between the management as well as our patients, to say, don't compromise so much for our patients. So we had to do a decongestion to say some patients can be assisted, but to protect them, we need to open the outreach areas so that the CCGs can go to them and the outreach team can go to them. And then those that in dire need of the hospital can come to the hospital. But all in all, I think we are getting there. Together, each one had to achieve more, and we are nearly winning this battle. I thank you.
Thank you very much. Very inspirational. Apologies that we are all the noises on the corners. We're just trying to anticipate problems. What we're going to try and do now, Sanele, if you give us 1 second, we're going to plug this laptop that I'm talking through directly into the speaker, and we're just going to make sure we can make you audible. So let's just try and do that. Sanele doesn't have a presentation, so that makes it simpler. And then what we'll need to do this afternoon, so for everybody on this call this afternoon, we are going to create 4 different links for the 4 different rooms. And there'll be 1 laptop in each room linked into Zoom, which will make it easier. Okay. On the Zoom chat, it will be difficult for them if they go out of Zoom now to access the Zoom chat when they have to link in this afternoon. We'll make a plan. We'll make a plan. Okay, I'm plugging in. Sanele, could you please unmute and just give us a test there? Sanele,
Hi everyone, can you hear me?
Yes, we can hear you. That's very exciting. Do you want to put your video on?
Yes, can you see me?
Would you make me host, please? Dr. Muller, Madeleine Muller. Am I a host? Oh, that's not going to help, actually. Should we make Sanele host? There we go. Just make Sanele. Oh, if you make me host, then I can do that. Sorry, apologies. Oh, Dikanati is still host. Would you make Sanele Ngobo host? Oh, there we go. Sanele, yeah, you can put yourself on speaker. Let's see.
Yes, can you still hear me?
Yes, we can. Perfect. And can you put, see. And we can see you. Okay, great. So Sanele, yes, I think you can unmute. And we will try, yeah, at the moment you are visible to the group here. For those of you on your phones or on your laptops, who is host at the moment, Sanele? The challenge we're having at the moment is that the video recording is actually going through 1 laptop and the sound is going through another laptop. So the problem is, for those of you that can't set which speaker you look at, you're going to pick up the speaker who is speaking, which at the moment is my picture, unfortunately. We apologize. We'll try and sort that out. I'm just wondering, can we make Sanele host? So when he starts talking, he becomes speaker. At the moment, when he's talking, it won't show because the video is playing through there. Okay, so Nele, just unmute yourself.
Yes.
Yes, great. And you can speak, and if everybody can please mute themselves. So Nele, I think just get started, and we're going to try and sort out the little technicalities on WhatsApp as we've been doing.
Thank you very much, Chair.
Hold on 1 second, just one more. Yes. Okay, great. Yeah, so Stephanie, can we have some ideas what we're going to do with the program? Yeah. So we're going to adjust the program. Sanele is going to be not brief, not too brief, but concise, hopefully. We're going to take a very quick lunch, and we're going to aim for Mark to speak to us at 1:30. So that's our aim at the moment. 1:30, no, is it 1:30? Yes, 1:30. Okay, so apologies again. So Nela is going to speak, and then we're just looking with the restaurant here and with our delegates here on how we're going to when we're going to schedule the Mark's equity speech. So Nela, you can unmute and start. Welcome. Thank you very much, representing the Clinical Associates and PACASA.
Thank you very much, Chair. Program Director, Honorable Dr. Poppy Ramatuba, I understand she was with us this morning. The leadership of PACASA, the leadership of RuDASA, the leadership of RuNurSA, the leadership of RuReSA, all the students and all distinguished guests who are here with us, I greet you all. Thank you very much to Sisu Utabisa, who was speaking before, and she explained the meaning of her name. Maybe I must also explain to everyone that Sanele means enough. I think now it is enough with COVID-19. We have to deal with it, and we have to make sure that we deal with other chronic illnesses. My name is Sanele, which means enough. Ladies and gentlemen, we highly appreciate the presence of the Honorable MEC. I think it was quite very important for her to be with us today for many reasons. I think she has been quite very involved and hands-on in the Limpopo province. She has been available when there was a need for her to be available, and she has led by example to say that let us go outside of our comfort zone and be in the communities and be in the clinics and hospitals. Leading from boardrooms will no longer work in our country. Ladies and gentlemen, as you all know, 2020 and 2021 has been a very difficult year for our people in general and healthcare workers in particular. This also extends to all clinical associates. We have been reminded that healthcare should be the #1 priority for our country. One thing that we now know for sure is that we can no longer achieve sustainable economic growth without a strong and quality healthcare for all. We now understand that for us to move as South Africa, as a country which is developing, we need a very strong healthcare system to be able to respond, because what we understand now is that an epidemic can highly affect and have a huge impact in terms of the economic impact and all the other spheres of government. So healthcare now should reclaim its position as the #1 priority for South Africa, in particularly the rural health care, because we have now realized that once you have a quality health care for few, it does not really help you, because with conditions like COVID-19, you need a community approach, you need a global approach where all communities come together, whether you are rich or poor, white or black, wherever you are coming from. We all need one another. We all need to work together and equally or distribute the resources in accordance to the needs, as the principle of equity says to us. Ladies and gentlemen, we have been reminded that quality healthcare for all is no longer an option. It's a must. It must reclaim its position as the #1 priority in our country. Universal health coverage can't be delayed anymore. The MEC this morning spoke quite very strongly about the NHI, and I want to speak strongly about it also and say that universal health coverage needs to happen, and it needs to happen now, because we are having COVID-19 today. We don't know what is coming in future. We don't know what other pandemic is coming into our country. It is for this reason that we need to build a very strong health system with a very strong health workforce, which is able to respond to the needs of all our people. We need to make sure that we move together forward using the tool of universal health coverage. Without equity, we can't win against COVID-19. Without equity, we can't win against quadruple burden of diseases. Without equity, our people, our rural communities will be left behind. Let us relook at the structure of our healthcare system and say, how would universal health coverage benefits our people who are coming from the rural communities. Let us make sure that whatever intervention that we come up with in the health system is not only reserved for those in the urban communities. Let us make sure that if we invest money in the national health insurance, it also strongly benefits our people in the rural communities. And we must not have the inequalities which we have heard some of our previous speakers talking about. The distribution of healthcare workers within the urban and the rural communities still it shows us that there is still a huge need to relook at this and say, how can we redistribute these healthcare workers in making sure that people who are living in the rural communities are not left behind. Universal health coverage should never be reserved just for the urban communities. Ladies and gentlemen, we want to caution the global community and call upon the WHO to ensure that they facilitate the distribution of COVID-19 vaccines in accordance with the need. It is highly unfortunate that some other countries are already talking about boosters, while many other African countries still do not have even a single dose of vaccine. We want to say, let us make sure that we rally behind those who are calling for equity in distribution of vaccines. We now know from the scientific background and from the scientific papers that have been presented to us, we now understand that vaccines can assist us, strongly assist us in terms of dealing with COVID-19. We understand that it will almost be highly impossible for any country to effectively defeat COVID-19 without vaccines. So we are therefore calling upon our different countries to look seriously, and the World Health Group to also advocate for equity in distribution of vaccines across the different countries, even across South Africa. Let us make sure that all communities, including the rural communities, have access to vaccines as they need those vaccines. Ladies and gentlemen, we are not only affected by COVID-19, parts of the country in South Africa were affected by the unrest, and we saw some clinical associates rising into the occasion. I want to make an example with two clinical associates working at Austin Hospital. These clinical associates faced an unfortunate situation where almost all healthcare workers, or most healthcare workers, including doctors, were unable to have access to the hospital because of the protest. But they rose to the occasion. They were seeing many different patients coming from different parts of KwaZulu-Natal, and many of them, which was part of them were gunshot wounds, some were stabbed, and they worked through day and night to see all these patients. Now, this is an example of a workforce that is needed in our country. The need to have clinical associates is now even more important, as we have seen in our country, that when we experienced COVID-19, while it was unfortunate, but for clinical associates, there was a large number of posts which were created to absorb clinical associates. But it cannot be true that clinical associates are only going to be needed when only there is a crisis. We understand now that we have seen the effectiveness of clinical associates, and we should continue moving together with clinical associates. In Limpopo, we had quite a very good example of utilizing clinical associates in Polokwane and in Mokopane region, where clinical associates were employed through the private-public partnership. In this partnership, clinical associates were employed to oversee and to support multiple clinics and work together in training community health workers, in assisting them in terms of clinical care. And we have seen from this particular approach that it has been a game changer in community-based oriented primary care. Ladies and gentlemen, we all understand that for NHI or for universal health coverage to be successful, we need a very strong community response in terms of making sure that we are able to deal with the quadruple and overgrowing burden of diseases in our country. We need to move away from the hospice-centric approach and move towards a preventative approach. It is through community-oriented primary health care that we can be able to achieve this particular goal of making sure that we are in communities and we prevent conditions. Through COVID-19, we have now learned that it is important for us to take a preventative approach to wear masks, and to do many different things as a form of prevention. This model of preventing people from being infected with COVID-19 is more effective than the one of having to deal with those who come to our hospital. We're now saying, let now this be an example. The approach of community health workers being in communities, screening people and working with those who are already infected should be taken to other different challenges that we are facing in our healthcare system. Let's do the same for HIV. Let's do the same for hypertension. Let's do the same for TB. Let's say it cannot be right that we have a condition like TB, which can be curable and preventable, but yet we are unable to deal with it. It remains #1 leading cause of death in South Africa. Why is it like that? It is because we only wait for people to come to us in hospitals when they are sick before we can be able to assist them. We have now seen the involvement of clinical associates in working together with community health workers and nurses who are supporting these community health workers. In the clinics around Mokopane region, we were having community health workers, about 12 per team, who are supervised by a nurse, mostly a registered nurse, and we're having a clinical associate overseeing a community or overseeing multiple clinics who are then reporting to that one clinical associate. And we have seen that through this particular process, we are unable to change the game and make sure that we are in the communities, take a more preventative approach in our communities. Ladies and gentlemen, as PACASA, we would want to take this opportunity and use it to also have our annual general meeting where we are going to elect new executive leaders for our we also want to encourage all our healthcare workers. Can I continue?
If you finish eating, we'll go together.
Please just mute. Can Muti please mute your phone?
Ladies and gentlemen,
you can continue. Sorry about that.
Yes. Ladies and gentlemen, as I'm about to close, I want to encourage all of us to take an approach where we listen to our communities. Let us listen. What are their challenges? What are they complaining about? Why don't they trust our message in terms of vaccines? Let us make sure that we share information to them. But in doing so, we need to make sure that we listen to them and we try to take an approach of making sure that we move together with them. We do not leave them behind. When they speak, when we see fake news appearing in media, when people talk about vaccines in sentences which we know that those things are not actually true, instead of jailing those, let us make sure that we go to them and we try to prove to them that actually what they are saying is not true. Let us take an approach where we do not criminalize those who don't believe in what we believe in, but we rather listen to them. We rather clearly try to understand what are their challenges and try to move together with them and explain to them. Because some of us, like myself, I am vaccinated and I trust that vaccines are working. But I understand whenever I visit rural communities, there are still many people who still do not understand how these vaccines work. And if we allow those who spread fake news to have a more powerful voice than us, we are going to struggle in terms of vaccinating as many people as we would want to vaccinate. We want to say, unfortunately, as PACASA and as clinical associates, we find ourselves in a very difficult position where we recently had to now involve Chapter 9 institution in terms of making sure that we work together with the department and find solutions for the challenges faced by clinical associates. This is important because the challenges faced by clinical associates has a direct impact on patients, has a direct impact on patients who are in the rural areas. We want to say that we are still committed to assist and to work together and deal with the current pandemic. We understand we are facing COVID today, but there might be another pandemic coming tomorrow. And for us to be able to respond to that, we need a very strong healthcare system to do so. Ladies and gentlemen, we wish you all enjoy the Rural Health Conference. We wish we all robustly engage and change ideas and learn from one another and have communicate and create networks through this particular conference, which we think is one of the most critical conferences in our country, because it speaks for the voiceless. It speaks for those who are in the communities who are mostly always left behind. Let us enjoy this particular conference. I thank you all.
That was very inspiring. Thank